Hi, everyone. Welcome to week 4 of the Mastering Hormones Bootcamp put on by Vibrant Wellness. We're so happy that you are all here. And this week, we are blessed to have Dr. Sharon Stills with us again. She laid some great foundation work for us last week. And today we are going to dive into being an effective hormone practitioner for your patients. I'd like to take a minute to reintroduce Dr. Sharon Stills. She's a licensed naturopath medical doctor who has over 2 decades dedicating service to transforming women's health, has been the guiding light for perimenopausal and menopausal women, empowering them to reinvent, explore, and rediscover their vitality and zest for life. Her pioneering of the Red Hot Sexy Menopause program encapsulated her philosophy to reinvent your health, explore your spirit, and discover your sexy. This unique approach has revolutionized the way women experience their transformative years, making her a sought-after expert in the field. The opening of the Stills Health Clinic in her new 7,000 square foot clinic in sunny Scottsdale, Arizona in late fall 2024 is going to mark another milestone of her mission to provide unparalleled naturopathic care. There, with her son, Dr. Ben Stills, they will be providing unique diagnostic and therapeutic options addressing all forms of chronic illness, including but not limited to cancer, autoimmunity, COVID-20, and of course, menopause concerns. This venture follows her previous success in founding and running one of the largest naturopathic clinics in the country. Dr. Stills' personal journey of overcoming her own serious health challenges underscores her commitment to the wellness path she advocates for her patients. Her life is a testament to the principles she teaches, from embracing a healthy paleo diet and a rigorous vitamin regimen to prioritizing restorative sleep and physical movement through yoga, hiking, and dancing. Please help me to welcome Dr. Sharon Stills for this week's session of the Mastering Hormones Bootcamp. Thanks so much for joining us today.
Thank you for having me, and thank you for that intro. It's always fun listening to your bio being read. Hi, everyone. I'm just super excited to be here, and I'm super excited if you were here last week. You know, we had a ton of tech problems, and I'm not moving around weird. Last time we had a bad connection. I don't know what was going on. Then I disappeared, but anyway, you can see me. So I'm just thrilled about that. I'm thrilled that you're taking the time to be here. This is such an important topic, and I want to do as much justice to it in the little bit of time we have, just really planting some seeds and changing the way you think about dealing with these patients, these women who really need our help. So just to recap, last week we just talked about, basically, for those of you that weren't here, or those of you that need the recap, because it never hurts to hear something more than once, but we were just talking about how perimenopause can begin as early as in a woman's 30s, and that we shouldn't overlook hormones as being a part of the problem, the imbalance, when women are complaining from anything from mood disorders to urinary tract infections to hair loss to sleep issues, to burning in the mouth, to joint pain, to immune imbalances, to autoimmune disease, to all of these things, that we really want to open our minds and think about hormones as more of a part of the picture than just regulating our hormonal cycle, our menstrual cycle, allowing a woman to get pregnant and carry a pregnancy to full term, or the menopausal transition. That hormones are intricately related to every system in our body, from our brain to our bones, to our genitourinary tract, to our immune system, to our cardiovascular system, to our lungs, to our GI tract, to everything. And so when a woman loses her hormones as she's going through that perimenopausal, menopausal transition, we want to really be paying attention. We want to really be replacing the lost hormones as a woman is losing them and not waiting. But that if a woman has waited, if she's been gaslit, if she's been given misinformation, that it's never too late, that even a woman in her 70s or 80s who's never had hormones can still benefit from the proper replacement. And so today I want to go through some of the highlights, some of the big points about what you need to be thinking about when you are working with a woman and her hormones. And so that's why I titled the slide, How to Be an Effective Hormone Physician, because there are a lot of people out there in her field who take a weekend class and hang out a hormone shingle because we know everyone's looking for hormone help. And so I really, I'm going to give you tips today, but this is just the tip of the iceberg. I was talking with Dr. Kim before about maybe doing a deeper dive, a real educational program, but you can really, really learn a lot. Vibrant, when you do tests with them, you can have a clinical review for a half hour with someone who works on the Vibrant staff. That is how I learned a lot of what I do, because I always call them, at least when I initially start running a test, and go over the test. And then they have these amazing guidebooks, playbooks on each test they do, that their hormone one is like this thick, and it goes through each metabolite, each hormone, each everything, and really dives deep. So if you want to learn, those are some great, great resources that can really put you ahead of the game just for starters. So let's start with testing, because there is so much confusion about testing. And so this is what I tell patients. I say, or women who are students of mine or attend my summit, I say, if you want to understand if someone is a good hormone doctor and good to invite onto your team, you can just ask them, how do they monitor the hormones? And the majority of physicians out there monitor hormones in the serum. And that is very, very misleading and can never give you the whole picture. It's a snapshot of what's going on in the serum. It doesn't talk about what's happening in the body, in metabolism, at the cellular site, inside the cell. And so it is not a good way to monitor hormones. Now, of course, you can monitor an FSH or an LH in the blood. That's very accurate. You can monitor a DHT, which is a dihydrotestosterone. If you want to monitor that in the blood, you can. You also get it in the urine. You can monitor an SHBG, which is sex hormone binding globulin, which is important because this is a protein that binds hormones. It's kind of like the hormones get on the bus. The bus is SHBG. And if it doesn't stop at the bus stop, if the bus just keeps going, then the hormones never get off. They never get off the stop, and they never get to the cells, and they never have an effect. So you never get the benefit, which is why, for example, if you're monitoring in the blood and you're looking at testosterone, which sometimes can be accurate, but often is not. So I always go to the 24-hour urine. But you want to monitor free hormones that aren't bound, because these are the hormones that have gotten off the bus and are knocking on the cell's door and entering inside and having a reaction. You can monitor vitamin D, which is a hormone, even though it's called a vitamin. You can monitor insulin in the blood. You can monitor parathyroid hormones. So there are hormones that can be done in the blood. And I preach 24-hour urine. I've been doing 24-hour urine testing for 23 years. As soon as I started practicing, I got educated, and that's what I started using. But I don't want to mislead you and think that blood isn't important for other things, because blood is very, very important. My patients are known to get 20, even 30 tubes of blood drawn. I run well over 60 markers when I'm evaluating a patient. I was just saying this to a patient the other day. At the bare minimum, what you need to do with me every year is have your 24-hour urine hormone test done and a full blood panel. So blood is very important. For instance, thyroid. I definitely rely on blood for thyroid. And when we're thinking about hormones, and thyroid is so misunderstood, but I just want to take a minute. You want to be running your TSH, your free T3, your free T4, your reverse T3, which is often not run and is very important. It dictates how you will prescribe thyroid hormone. And you want to run the antibodies, the TPO antibodies and the thyroglobulin antibodies, because if someone has antibodies, and it's interesting because I hear a lot, oh, Hashimoto's, autoimmune mediated thyroid is 90% of the cases. I have to tell you, in my 23 years of practice, that is not the case. I see a lot of women who don't have antibodies and they just have a primary hypothyroidism. But you want to be running a reverse T3, because if the reverse T3 is elevated, and I'm not talking lab range elevated, I'm talking optimal range elevated, then you wouldn't want to give a T4 T3 combo, because it's just going to create more reverse T3. So you would give bioidentical T3 alone. So I'm going to stop that tangent because that could take up the whole 45 minutes of talking about thyroid. But basically, just to say that blood work is very, very important, but not when we're talking about sex hormones. So then let's go to saliva, because there's a lot of doctors out there who are saying, oh yeah, we get it. We don't do blood work, but we do saliva testing. And that drives me insane, because saliva testing is also inaccurate. You cannot see the metabolites, and you cannot monitor hormones in the saliva. They will often falsely elevate. And I've seen this time and time again. Patient comes into me, was seeing another doctor, was monitoring through hormones, and they took their hormones away because when they were monitoring them, they said, oh, your levels are too high or overdosed. But they're always going to be high. Once you're on hormones, you cannot rely on saliva. However, you can get the cortisol levels in the urine that Vibrant does, which is very helpful. And if you wanted to do a saliva test, say you just want to do a spot check on cortisol and you didn't need to do all the hormones, you can do a saliva test, because saliva is very accurate for cortisol. You do not want to be using blood. A lot of doctors do awakening cortisol, a morning cortisol in the blood, not accurate. And the really important thing is you want to see circadian rhythm. So that's why in the 24-hour urine with Vibrant, we're getting these 4 samples and you can see the circadian rhythm. It's not enough to know if someone is producing enough cortisol or too much cortisol. It's really important to know when they're producing it, because it's 2 separate things. If there's not enough production, or if the circadian rhythm is off and they're not producing enough, they don't have that cortisol awakening response, and then they have high cortisol in the evening when the cortisol should be low. And again, a very big misnomer out there is everyone has high cortisol, and high cortisol is the cause of all that ails you. It's the cause of your menobelly, it's the cause of your brain fog, it's the cause of your hair falling out, it's the cause of your fatigue. But again, I can tell you, when I run these tests, especially in the perimenopausal, menopausal age range, most of these women have depleted cortisol. Their adrenals have already said, we're tired. We can't do this anymore. We're going away. We're going to Hawaii. We're going to lay on a hammock, and we're no longer producing cortisol for you. So don't be fooled. And again, I go back to that test, don't guess, because there are, right, like we think of low cortisol as fatigue and high cortisol as wired and tired. But I can tell you, often the symptoms can mislead you. So you have to go to what I have listed next, the 24-hour urine test, which is the gold standard. So honestly, like, if you're going to be a hormone doctor and you're not running 24-hour urine tests, you're not utilizing Vibrant's test, you shouldn't be a hormone doctor, because you're not doing it right. You're going to mislead patients. You can do more harm than good. So, you're here, you're taking the time. Like I said, this is the tip. you've got to do the deep dive, and you've got to start running 24-hour urine tests on your patients. And I think I mentioned it last week, but I'll certainly mention it again now. I do baseline tests because you never know. Just yesterday or the day before, I had a new patient who was 65 and had never been on hormones, had been postmenopausal for a while. Her estrogens and her progesterones were tanked, but her testosterone was not. She was still producing some testosterone. And so I didn't prescribe testosterone for her. Now, had I not known this, had I not tested, I would have automatically assumed that everything was tanked. So it's really important that we see what a woman's baseline is, because sometimes you're surprised. We also want to look at how a woman is metabolizing. Does she metabolize down the more preferential pathways, or is she metabolizing down the pathways we're not as interested in? And we want to see what her baseline is. Some women with a little bit of estrogen they're still producing, they metabolize beautifully. So then when we give the bioidentical hormones, we then do another 24-hour urine test 10 weeks after consistent use of the hormones. Now we need to look, are her levels coming up? How do her metabolites look? Do they still look good? Do we now need to give some supplements if they're not looking the way they should be looking? And we want to compare, how is she feeling with her test results? If her test results look good and she feels good, because after 10 weeks of the proper dosing and the proper hormones, she's going to feel better. Are 100% of her symptoms and concerns going to be gone? Maybe. Yeah, I see that a lot. Maybe not, because maybe there's some other things that are interacting that are making her feel the way she does. But often it's like, poof, everything is better. So when we recheck in 10 weeks, and everything looks good and she feels good, then I put the patient on a yearly schedule. And if she wants to get hormones from me, she has to commit to doing the 24-hour urine every year. And we keep track of this in my office. Just a clinical thing, we offer a 10% discount if they buy their 24-hour urine test that they're going to need in the future. If they buy it ahead of time, it gives them a little incentive. Then they already have it, and then we don't have to go chasing them. So it's a little less, so it's a win-win, less work for my office staff and a discount for them. And if they don't do that, then we mark it down, we have it flagged, and we reach out and we make them buy the test. And if they don't buy the test, we cut off their hormone prescription. And then they buy the test, because no one wants to give up their hormones because they make them feel so good. So that's a little bit about testing. I'm going to answer questions at the end. So I'm going to move on from here. But if you have questions, put them in the chat and we'll get them answered. But that's just giving you a big overview of what you should be using. And I guess I'll throw in again, stool testing, urine testing for organic acids, for toxicity, urine testing for neurotransmitters. These are all things that I'm doing as well. If a patient is not still feeling well, or she comes in and she's on medication, we can look to the neurotransmitter testing. I love that Vibrant's neurotransmitter testing has oxytocin in it. Oxytocin is not really talked about a lot. It's not really tested a lot. Oxytocin has huge implications in mood. It's the bonding hormone. It's the orgasm hormone. You get a hug, you get oxytocin, you play with a baby, you pet your doggy. Most women are very depleted in oxytocin. And on my slide, I'll talk about how we replenish it. So let's move on. So I just wanted to put up some sample reports. Tech is not my forefront, being a doctor is. So I just wanted to, I'm going to talk about some things that may not be listed here, but I just wanted you to see a sample report. I wanted you to see how progesterone, hopefully you could see my little arrow, but how progesterone, how there's the beta pregnanediol, the alpha, the allopregnenolone, which is really important in hitting GABA receptors and causing that anti-anxiety effect. I call progesterone, it's the hormonal Xanax, and it changes women's life. I have patients all the time who haven't slept in years. I put them on progesterone and they call the office the next morning. They're like, I slept 8 hours straight. I haven't slept like this in years. And so this often progesterone is one of the first hormones to decline as a woman is perimenopausal. And if she's stressed and pulling through to her glucocorticoid production instead of keeping it with progesterone, she will have what's known as an estrogen dominance. And estrogen dominance can be because there is too much estrogen, because we have all these xenoestrogens in the environment that we're dealing with today, from plastics and body care. But it also can be because a woman just doesn't have enough progesterone, or she has too much estrogen, comparatively speaking. And xenoestrogens, these exogenous estrogens, these are not what we want in our body, but they don't have the same mechanism of action. So when we're looking at estrogen metabolites, we look at a 2:16 ratio. We know that the 2 is anti-inflammatory, it's breast cancer protective. We know that the 16 is proliferative, so it makes things grow. And so we don't want too much of it, but we want enough of it so that it doesn't cause osteoporosis and it doesn't lead to bone loss. So I said it last week, I'll say it again, it is very Goldilocks, and being able to dig in and look deeply at all of these levels is what is necessary to really help a woman. And again, you always want to remember, if a woman is high in something, but it's not dangerous and she feels good, it may be where she needs to be. These are great. We have low, optimal, high ranges, but basically some women need to run on the higher end. That's where they feel good. And so, we say it's the art and practice of medicine, and there is certainly an art form, as well as the science, as well as the data that we get in these results, to helping a woman feel her best. But I would say this woman is not sleeping because she has low of all her progesterone metabolites. Let's see. So you can see here, there's more levels. We're diving in. There's comparison of progesterone to estrogen. That was what I was talking about. With dominance, we don't want to have too much estrogen, not enough progesterone. That can put us into a proliferative state. But I just want to go back. I know I talked about estrogen last time, and I just want to go back because there is a lot of misinformation out there. I was just having a big conversation with Lindsay Berkson yesterday, who, if you don't know Lindsay Berkson, go follow her Substack. She puts out a lot of good information. And there's doctors out there now touting that estriol is dangerous, that you should only use estradiol, that prescribing Biest is not a good idea. They're saying they've dug into the literature. They haven't dug into the literature, because if you dug into the literature, you would see that estriol is anti-inflammatory. Estriol protects against cancer, and estriol is E3, just to remind you all of that. It protects against breast and ovarian and colon cancer, and especially if you have cancer already. So estriol I'm using to treat active cancer. It upregulates adhesive proteins in between the gut cells, the enterocytes. So it's helping to seal up a leaky gut, which, if you're doing vibrant stool testing, which hopefully you are, you're seeing that zonulins are just off the chart on like the majority of all your patients. When I see a patient come back with a normal zonulin, I'm like, what kind of unicorn are you? Because I'm just not used to seeing that. And when we are sealing a leaky gut, we are contributing to protecting or reversing autoimmunity, because a leaky gut is a major issue, along with viruses, along with metals, in autoimmune disease. So estriol is actually very protective against cancer, against autoimmunity, against inflammation. And so I was watching the debate last night. Anyway, so it's really important that you get your knowledge from credible sources, and I see it all of a sudden, all these MDs are starting to parrot this wrong statement, wrong belief. Other doctor, and I don't like to call out people, but another big doctor saying estrogen causes cancer and buy his DHEA drops, and estrogen is dangerous. This is doing a huge disservice to women. So I just want to make sure that you don't get sucked down a wrong pathway, that you are understanding hormones and understanding, not going with that party line that they're dangerous, that they cause cancer. Using estradiol alone puts a woman into a more proliferative state. I talked about last week the estrogen receptor sites. And so it's really important to remember that estriol is hitting the beta receptor sites, which are inhibitory. So we really have to understand the different estrogens, the different metabolites, and what they're doing. And so I just want to really drive that home. So another thing that I love, because again, last week we talked about this terrain-based approach, that we're not just putting hormones into a body that we haven't paid any attention to, diet, to sleep, to the microbiome, to the toxic load, to the lymphatic flow, and so on and so on. And so I love that the 8-OHDG, right up here at the top, is measured when we do the 24-hour hormone urine testing for patients, because this is a marker of oxidative damage. And oxidative damage can be caused by increased cortisol, which you can see in the test. It can be caused by pollutants, BPA, heavy metals. It can be caused by cancer. It can be caused by EMFs, by diabetes, even acute exercise. So I make sure patients, are taking it easy and not overdoing it the day of their test. And so, but if someone has high oxidative stress, we need to work on that so that the hormones have a happy, healthy place to be. And so it's just a reminder to think globally. Really important, when we're looking at sex hormones, we're looking at the progesterones and the estrogens, and then we're looking at the androgens, which are DHEA and our testosterone. And you can see here that the urine test is diving deep. It's looking at the metabolites. It's looking at testosterone. It's looking at the DHT. A lot of doctors put patients on testosterone. They never measure their DHT. And then they wonder why the patient's hair is falling out. And it's because they're metabolizing down that pathway. And there are things you can do to stop that from happening. But if you don't check, then you never know it's even happening. And so DHEA and testosterone often don't get enough play in women's health. And when we think about women's health, we think about menopause, we think about progesterone and estrogen. So I want to make sure you're really looking at DHEA and testosterone as well. And then melatonin. I love that we're getting this diurnal look at melatonin, which has this, I think of seesaws. I think of the thyroid and the adrenal glands on a seesaw. Thyroid goes up, adrenals can go down unless you're supporting them, which is why I always look to the cortisol levels first before I put anyone on thyroid hormone. And if their cortisol is low, I'm supporting cortisol for at least 3 to 4 weeks before we're introducing thyroid. And so the same with melatonin. If someone's cortisol is high at night, you'll often see that the melatonin is low at night. And so you can use melatonin, you can use phosphatidylserine, you can use L-theanine to bring cortisol down and to increase melatonin. And melatonin is so much more than just a hormone for jet lag or a hormone to help you sleep. Of course, those are important things. Sleep is, everyone's superpower that they need to get on board. But melatonin is also a very strong antioxidant. When I'm working with any patient dealing with cancer, pretty much, and I'm not a cookie cutter kind of doctor, but 20 milligrams of melatonin is kind of a standard prescription that I'm giving them. But melatonin is also important for our mitochondria, for our bone health. So for women who are dealing, you're going to see one of the biggest concerns when a woman is peri and postmenopausal is she's losing bone, she's becoming osteopenic, osteoporotic, she has joint pain. And so melatonin can be an important player. So I guess the take-home clinical pearl here is if a woman is sleeping well, these melatonin levels are in range, but if a woman is sleeping well and she's in the red, her melatonin is low, you still want to give her some melatonin because of all of the other benefits. Before I started looking at these urinary diurnal melatonins, I would sometimes think, okay, you're sleeping, you don't need melatonin, but melatonin is needed. It's very effective for lung health. It was one of the things I was using to treat COVID in the early days. So very, very important hormone that often gets overlooked and doesn't get tested anywhere else. So again, just another really important reason to be using the 24-hour urine test. So let's talk about location and dosing. Because first you're doing the testing and you're going to learn how to evaluate a test in tandem with listening to your patient, with listening to how she's feeling. So as much as I tout and mandate 24-hour urine testing, and I didn't say, let me just go back and say something. When I was talking about how we do it 10 weeks after and then yearly, I just want to say that sometimes after the 10 weeks, there are levels that are still really out of balance. So typically in my practice, by 10 weeks, a woman has at least 75% improvement in what she is worried about or what, her chief complaints were. But often when we rerun the 24-hour urine test, there's still some metabolites that are out of balance or don't like the way the cortisol looks. So it isn't always, baseline 10 weeks yearly. Sometimes they have to test again in 3 months or 6 months. And again, that is, a clinical call. But what I want to tell you from a practice standpoint is I have this conversation. My staff has this conversation with women before they even become a patient. And then I let them know again in the first visit, look, if you're going to be receiving a hormone prescription from me, this is what you're committing to. So I let them know that, you're going to have to expect to be running these out-of-pocket tests. And so it's really important that you communicate, that you get your patient on board and that they know that this is what's going to be expected of them so they can plan and not, you don't want to surprise them and be like, oh, by the way, you got to do another 24-hour urine test. Oh, you got to do another one. I let them know exactly what I'm telling you. You're going to do a baseline, another one in 10 weeks. And hopefully after the 10 weeks, we put you on a yearly schedule, but that might not be the case depending upon what your results look like. So location, location, location. It's not just important in real estate. It's important in how we provide hormones. So I can't tell you again how many times I have seen a patient come in, maybe she was on the right hormones, but they weren't being administered properly. So I kind of broke down a little here, the big ones. Oral hormones. So I also see patients come in on transdermal DHEA, which I learned a long time ago, doesn't absorb. So you can save your patients some time and money. So liposomal pregnenolone, DHEA, melatonin. Those are the best ways for absorption. They're the most cost-effective ways, and they're going to move the numbers on the 24-hour urine test. I also, vitamin D, I like liquid. It's a fat-soluble vitamin, so we should give it emulsified in the way the body is used to receiving it. So often I see patients are on capsules and their numbers don't move until they get on a liquid form. Thyroid, definitely taken oral. Bioidentical cortisol, taken orally. And progesterone. So you'll see progesterone is listed under oral hormones and under transdermal, which actually, that is a typo. That should say transmucosal, and we'll talk about that in a second. So if you're taking notes, write transmucosal, because we don't do them dermally, we do them to mucosal tissue, so it's my bad. But you'll see progesterone is under both. And I have just learned throughout the years that progesterone cream is not enough, but very effective for doing certain things in the body. And progesterone orally is also effective. It really helps with the mood regulation and the sleep. So I prescribe both. I prescribe capsules and I prescribe cream. And obviously it's different for every woman, but I'll give you some averages. For progesterone, I might do like 50 milligrams, and we'll do that to the external labia, transmucosally, and then we'll do 100 milligram capsule. Now, some women need more than 100 milligrams orally. And so if they're not getting the benefits of a good restful night's sleep, of letting go of their anxiety, of feeling good emotionally, of not having mood swings, I will titrate them up by 100 milligrams. I usually don't go higher than 400 milligrams. I don't usually need to, but some women do better at 200 milligrams orally or 300 milligrams orally to feel their best. So you don't want to put someone on hormones and say, oh, I guess it doesn't work, right? I gave you the 100 milligrams.
Hold on. Dr. Stills, you're on mute. I don't know what happened. Nope. Hang with us, everybody. We got the microphone right back on. All right, stick with us. Sometimes we have a little technical issues, but we will get that right back on. Okay, so it's on mute now. Yeah, maybe if everyone just hang tight for a second. I'm going to have Dr. Stills leave and come back in, and then we'll restart right where she was with dosing at that point. I'm going to stay here. All right. So thanks so much, everyone, for hanging with us. We all love technology as long as it works. So Also remember that there is that hormone code, Hormone 2024, for $100 off of hormone test. So all of the information that Dr. Stills was talking about today, you can give it a try on yourself or on a patient to be able to use that. Okie dokie. She should be jumping right back in here. I see that there's a bunch of questions, and please note we are going to have questions at the end. I can see you, but I cannot hear you. Sorry about that. Mm-mm. Oh. Let's see here. Okay, I have that. Sorry, everyone. Not sure what has happened here. It shows that you're not. Oh.
Can you hear me now?
Yes.
Oh.
Okay. Add your slides back.
Oh my gosh, I was like,
That's okay. Just get, as
problems.
long as you get your slides back up on the stage, then we'll be good.
Okay. Sorry about that, everyone. I thought we were home free with the tech issues. Yeah, it was right there. Okay. All right, I'm back. So I was talking about progesterone, right, and titrating it up. Okay. So estrogen you want to do as a biased, contrary to the noise that is out there. Biased is a combination of estriol and estradiol, and a typical starting dose is 80-20, meaning it's 80% estriol and 20% estradiol. The beauty of having the 24-hour urine is that you can really see how is the estriol coming up, how is the estradiol coming up, and then you can make changes. So some women will do great on an 80-20, but some women need to be changed to a 70-30 or a 65-35 or even a 50-50. And the only way you can accurately gauge that of what a woman needs due to how she metabolizes it is by looking at the 24-hour urine. But that is how you want to give estrogen. You don't want to give it orally. That's when you can have issues with blood clots and inflammatory markers, CRP going up. So that's really important. Intravaginal would be an estriol. So we compound an estriol gel. I tried putting hyaluronic acid in it because I think that's so good for the vaginal canal. It was really hard to get a good compound. It got very gunky. So we've just gone back to just using estriol. But the estradiol that a typical OBGYN gives in, in a prescription form. A patient had one the other day. It had parabens in it. It had sodium lauryl sulfate in it. So these are certainly things you don't want to be sticking up your vaginal canal. But if a woman has vaginal dryness, I mean, I see so many women have been suffering for so many years. 2 weeks and her suffering's gone. You do estriol gel, you compound it, you have them do a 0.5 gram every night for 2 weeks as a loading dose, and then as needed, which on average ends up being twice a week. Some women are above average, they need it more. Some women need it less. You let them figure out what their dose is. Oxytocin, which I mentioned before, we do in a nasal because it's a very unstable molecule, has to be kept in the fridge, has to be reordered every month. It's only good for 30 days, but you want to do it as a nasal spray. And then injections, peptides, which I don't have time to get into right now, testosterone for men, I always do testosterone injections. Women can do this too. It's not normally necessary, but they can if need be, if they're not absorbing the cream. You want to run, stay as far away as possible from pellets. They overload the body, they overdose the body, and they cause havoc in the liver. They cause havoc in the woman's body because they get like a testosterone high and then they crash, and then there's nothing you can do for 3 months. I very, very rarely, I may have mentioned this last week, but I've worked with tens of thousands of women at this point. And I think I've seen 2 who actually were on pellets and their 24-hour urine test looked okay. So again, I'm a big fan of if it's not broken, don't fix it. And so even though I speak out and I don't like pellets, I let these 2 women stay on their pellets because it was working for them. So you want to have your framework, your understanding, and then you want to make sure you're flexible and you are dealing with the patient in front of you. So we're going to go few minutes over because of our technical difficulties. So here is a picture of a vagina. This is actually taken from our handouts that we give to patients. And I just want you to see the labia majora. This mucosal tissue is where we apply the hormones. And pretty much everyone out there says, apply them to your wrists, apply them to your belly, apply them to your thighs. And what happens is you get dermal fatigue. The hormones start to get stuck in the fat tissue. You have to keep using more and more and more because the patient's starting to not feel good. So by applying to the external labia, the labia majora, the moist tissue, not into the vaginal canal, the only hormone that goes into the canal is the estriol. But applying there, you get great absorption and you can use less hormones. There is no reason to make a 65-year-old woman cycle and have a period. That's another fallacy that is out there, that women need to, build up their uterine lining and slough it every month to get the benefits of hormones. That's just not true. So we give the least amount to make the biggest effect, and the biggest effect is seeing that symptoms are going away and seeing the 24-hour urine. So we're not just guessing and going, okay, well, your hot flashes went away. You probably have enough estradiol to protect your brains and your bones. No, we don't know that unless we look at the 24-hour urine and we see, oh, good, the estradiol is in the right range. So very, very important. Important to monitor. So again, how we do it clinically, we get the baseline, we go over the baseline with the patient, put them on their hormones, and then I do a clinical check-in in 4 weeks. So it's before they're going to do their retest, and I just want to see how they're feeling. Typically patients are like, side effects. My patients don't see a lot of side effects other than good side effects. But, sometimes there are patients who are sensitive and they might have some breast tenderness, they might have some spotting or paradoxical reaction. So you want to make sure you're following these things. Sometimes they need a little less. I have some super sensitive patients that take like this teeny bit of estrogen. You would think it would do nothing, and they have these robust levels in their 24-hour urine test. They feel great. So again, you have to, there's a bell curve, and then there's our patients who are on every side of the bell curve. And often when you put a patient on hormones, if their body hasn't had hormones for a while, there might be a little bit of nipple tenderness. So I usually tell them, let's just give it a couple of weeks. If it's still persisting after 2 weeks, we're going to look at it. But often the initial complaints, by the time the 2 weeks pass, they're like, oh yeah, I'm fine. I feel great. And so, what are we seeing? We're seeing patients are like, we're doing it like bunnies, they're in their 60s and they're like, I feel like I'm 25 again. As far as my sex drive, they're sleeping better, joint pain resolving, hair growing, skin, nails, everything, urinary tract infections subsiding, all the things getting better. So it's really important to have that 4-week check-in just so you can track, because patients on the whole, they remember what's bothering them, but they forget things that were bothering them that are now improved, right? So we like to complain, but we often forget to go, oh my God, it's amazing. I don't have headaches anymore. I had a patient the other day was waking up with headaches every morning. And when we did her 4-week check-in, she didn't say anything about her headaches. And I'm like, what's going on with the headaches? She goes, oh, I haven't had a headache since I started the hormones. Like, she wasn't reporting that. I had to drag it out of her. So there is the testing. I already talked about that. I do like my patients to have a transvaginal ultrasound, especially if they have a history of estrogen dominance, PCOS, endometriosis, fibroids. We just want to make sure their uterine lining is staying, between 4 and 6 millimeters. It is important to, I think hormones are one of the best ways to protect against breast cancer. I'm not a fan of mammography. I do not recommend them. I'm 56. I've never had one. I never will, but I do thermography scanning, computerized regulation thermography, not picture thermography, not accurate. You want to find someone who's doing computerized regulation thermography, and QT scanning. We're going to be putting one, we already do thermography, and we get our new 7,000 square foot clinic, which is going to open in 2025. We're going to be doing those too. So look for someone near you who's doing CRT. It's the alpha machine, QT scanning. Get a relationship with them and send your patients so they can be scanned. I also like patients to have CT coronary calcium scans. We're using hormones to help with arteries, and this is a good way to check. And you want them to have a 0. That is optimal. And so my last slide here, supporting players. So hormones are a symphony. I think I've dug that in, right? We don't want to just give estrogen, progesterone, and testosterone and think that's all they need. We want to be looking at the 24-hour urine. We want to be supporting DHEA, melatonin, cortisol, thyroid, all the things. I just like to give a shout out here about DIM. DIM is so misunderstood. A lot of people think DIM is estrogen. They think DIM is for everyone. And DIM is not for everyone. Again, this is why we do 24-hour urine testing, so you can look at that 2:16 ratio. If it is low, you can give DIM, but many women are put on DIM. They've never been checked. Their 2:16 ratios are high, off the chart. And although, as I said before, that's good for protection against breast cancer, it is not good for the bones. So Goldilocks, Goldilocks, Goldilocks. We want to be 24-hour urine testing. I can't say it enough. And we want to be optimizing levels. We do liver support for all my patients. It's important to be supporting the liver. And we do receptor site report. We have supplement that we use. You can look to Lindsay Berkson again. I'll give her another shout out, but from Bioidentical, she created a great supplement for detoxing the receptor sites, because we want to make sure, it's kind of like you aren't what you eat, you are what you absorb. You better have enough hydrochloric acid. I don't know why my email is going off, because I know I turned it off, so sorry about the dinging, but at least you can still hear me. So you want to make sure you're supporting the receptor sites. So bare minimum, when we put patients on hormones, I'm making them take liver support. I'm making them take receptor site support as well. And then if they have a high 4-hydroxyestrone, which is the metabolite that's most closely associated with DNA damage and can be a risk factor for breast cancer, you want to use sulforaphanes, you want to look at magnesium, you want to look at glutathione, you want to be looking at their SNPs and their COMT. And so these supporting players are also very important when you are doing hormones. So I believe that's my last slide. Yes, it is. So I talked fast near the end there, but you could still hear me. Wait, you're muted. I can't hear you.
Thank you. Thank you so much. We have a lot of questions, so I want to jump right in.
Sure.
There's a little bit of an echo, so
I'm
hopefully
not
I'm
going
just
in
going to
and
put them up
trying
on the screen.
I want to go try it. I don't know why my email's dinging, but I'm afraid to touch anything because I don't want you to lose me again. So
Yeah, I'm not sure why there is an echo, but we're going to go ahead and just put this questions up here. Okay, so I'm going to go back up here. So we have a comment. If you can comment on this statement from ACOG from 2023 regarding testing and bioidentical hormones.
I don't. Why can't I don't understand the question. What is the comment?
If you can comment on the statement from ACOG on menopausal hormone therapy that adjunct hormone tests for prescribing and dosing bioidentical menopausal hormone therapy is not recommended.
Well, that's just ridiculous. I don't know what to say to that. I mean, why you would say adjunct hormone tests are not recommended. I mean, you just heard why they're recommended. I mean, that's just lazy medicine. That's improper medicine. That's part of the problem we're up against in the hormone field, that there are so many misconceptions and ridiculous advice given out there that it's confusing, which is why I'm really glad you guys came to Vibrance, hormone boot camp, because you're getting good information here. I mean, how could you not test? It's insane. So,
Very good.
that?
All right, we'll jump right over. So as far as retesting at 10 weeks as an acceptable time frame, would you do would it be the midpoint of the reference range for the hormones? What about the metabolites? Kind of where are you shooting for when you're retesting at that 10 weeks?
Yeah, so this is, a little bit of the art of medicine. And yeah, you want, like, I guess you're like asking this question from the perspective of like optimal, right? And so if we have a range of 0 to 100, we say 10 is not good, right? We want it to be between 60 and 70. And so, yes, there's certainly some truth in that. I like things to be at least middle, but a lot of times I drive things, higher. You have to, that's like what I was saying, you have to go back and forth with your patient and see. So I use the hormone testing as a guide. I want to make sure the metabolites are where they need to be, because we don't want to be driving inflammation. But some of the basic hormones, like progesterone, might need to be really elevated, because that's where a woman feels good. So as you practice and, you go back and forth with your patients, you start to get a better feel. So there's no, Dr. Kim and I were talking about this before, there's no like cookie cutter, this is how you do it, and you want everyone's this to be that. It varies. But you certainly want, typically, yes, midpoint is good. But say testosterone, some women don't need a lot of testosterone. So some women, if they're on the lower end of normal in the testing, but they feel good and, they're not having symptoms, I might keep them there. So it really depends, but hopefully that helped a little to answer your question.
Very good. Can you speak to why we would need estriol or E3 in a non-pregnant state?
Well, I talked about how E3 upregulates the adhesive proteins, it protects against cancer, it decreases inflammation, it supports bone health, it helps handle symptoms, it's good for the genitourinary tract, it protects against autoimmune disease. So there's lots of literature supporting E3. And so again, I would direct you to Lindsay Berkson. She is fantastic, and she does a lot of literature dives, and you can read more on that. But this rampage against E3, this beautiful molecule that I've been using for 23 years, is unfounded. It is very pigeonholed medicine, and that is not the kind of hormone medicine I practice. I practice terrain-based medicine. I practice doing what a patient needs in the least amount to get the biggest result. And so That's what I would say to that. I'm not going to go off on a tangent.
Very good. Okay, a couple questions about melatonin. I'm going to put both of them up there. One, we just kind of had a comment about 20 milligrams being a really high dose. So if you maybe want to comment on your dosing there.
Yeah.
And then the other one was, as far as melatonin, if it's adequate, would you still supplement?
So 20 milligrams of melatonin for a patient who's dealing with cancer is a very standard dose. And maybe you misheard, but I said that's what I use with patients who are dealing with cancer. A typical dose that I use with someone who's not dealing with cancer could be anywhere from 1 to 6 milligrams. So just to clarify that. And then if levels are adequate in melatonin, but they're not sleeping well, would I supplement? Not necessarily, because I want to see, if their melatonin is adequate, it might not be the reason they're not sleeping. So what's their progesterone? What's their cortisol? How's their thyroid hormone? How's their liver? What's going on with their blood sugar? Do you have a CGM in them? Are you looking at blood sugar levels? So there's a lot of pieces that go into not sleeping well. I would say, and I think I already said this, but I would say, like, if you want to, throw something that's going to have the greatest effect, it would be optimizing progesterone. I talked about titrating up the progesterone capsule. That is going to work more often than not to get someone sleeping.
Very good. Okay, do you have a recommended dosage for oxytocin?
Yeah, so we do, what is it? It's 40 IUs per mil that we compound, and then we do 2 sprays in each nostril, AM and PM. So it ends up being 8 sprays a day, and you can figure out the math on what that is per dose. But
Very good. Okay. Concerns about hormone transfer when applied to the labia.
Great question. We actually, I showed you my vagina handout. I didn't show you my syringe handout that we give to patients that we talk about this on. What I tell patients is, if it happens once in the heat of the moment, it's not like the end of the world. But yes, you have to be conscious. And, if you always have sex in the morning, put on your hormones after. If you always have sex when you guys head to bed at 9, have sex and then put on your hormones. You don't want to be continually giving your partner your hormones. When you rub in the hormones, within 30 to 60 minutes, they're gone, they're absorbed. I would say 60 to be on the safer side, because I'm cautious about things like that. But that is certainly something to pay attention to. Also, like urination, you want to try and urinate before you apply your hormones.
Very good. Okay. I think this is referring to the thermography machine.
Yeah, Alpha, ALFA, or just CRT, computerized regulation thermography. Some people call it thermometry. It's the same thing. You just want to be using, we are taking actual temperature readings with a wand. We're not just snapping a picture, which is not as accurate. And when you're doing the regulation thermography, you're looking at the implication of teeth affecting the hormones. It's the only real way to a diagnostic machine that is reproducible, that looks at the health of the lymphatic system. It's why I became obsessed with the lymphatic system, because when I started running these 23 years ago, I saw, lo and behold, everyone's lymphatic system is really inflamed and not moving. So that's the machine.
Okay, I think that is about it. We did have a question. Lindsay, the Lindsay that you were referring to, that's Berkson, right?
Berkson, Berkson. She's written some books. She's a dear friend of mine, and became a friend because I was like, this chick knows what she's doing with hormones. So she's not practicing, but she's a wealth of information. She has a Substack. She speaks out about a lot of these things. So I love to support her, because I think she, puts out a lot of good information there. Jonathan Wright is not really practicing anymore. But that is who I learned hormones from. So, reading anything that Jonathan Wright, he wrote the first prescription for Biest in the States. So, going back and looking at any books he's written can give you some interesting information as well. I mentioned last time, I'll mention again, Estrogen Matters, that book, The Menopausal Brain. You do need to take some time, do some reading and, get educated. Hormones are a very, to me, because I've been doing it so long, like hormones are like the easiest patients for me. But I also understand that hormones can be very complicated. And, I too sometimes have patients that don't respond the way I think they're going to respond, right? We tend to attract those kind of patients. And so, it's just taking a deep breath, having patience and thinking it through and looking at the pathways and looking at your test results, looking at the patient and piecing it together.
Good. We did have a couple more questions come in, and I think they're important, so I'm going to keep going with this. So as far as if you tested somebody's hormones and their toxins on the same day, and their toxins are elevated, their hormones are low, what would you treat first, or would you treat them concurrently?
So I don't have them do the tests on the same day. You're either doing your 24-hour urine test, or you're doing your toxicity test, or you're doing your neurotransmitter test. We don't have them do them on the same day. I always treat hormones first. So you can, like, in your brain say, well, the metals are affecting the hormones, so we got to detox the metals before we replace the hormones. That just makes patients suffer. I see patients who come in from doctors that have been doing, like, give them their hormones, but then work on the other things. But get your patient feeling good. Remember, a menopausal woman, whether she's carrying a toxic load or not, which, newsflash, we all are, right? She is losing her hormones. It's not because she's carrying a toxic load, it's because she's going through menopause, and that's what happens. So it's really important that we treat the hormones first. We not make someone suffer and tell them they have to detox for 2 years. Put them on their hormones and then start addressing the other things. They will thank you.
And I think there needs a clarification as far as labia application for all topical hormones.
Yes. Estrogen, testosterone, progesterone. If I have a woman doing, I didn't say this, and it's probably important, like if I have a woman doing Biest and testosterone in the morning, progesterone always at night, by the way, I didn't say that, but progesterone is very yin, estrogen is very yang. So progesterone at night, not in the morning, it makes you sleepy. But if I have her doing like estrogen and testosterone in the morning, often I'll have her separate it. Do one, wait 30 to 60 minutes, and then apply the other, so we make sure that she's getting the good absorption. Don't compound your hormones all in one. I see this a lot. Doctors think they're trying, they think they're trying to be helpful. Oh, we'll put your estrogen, your progesterone, your testosterone all in one cream. You don't get the absorption. So we use syringes, or we use Topiclix for patients who don't like syringes. Every hormone has its own dispenser, so we can control if we need to go up or down on one, and we can make sure you're getting good absorption.
Great. All right, we've had several questions about referring to you if you are, what state you're in, what types of patients you see, and then also resources and other things. So if you have other educational avenues for providers to connect with you, that would be great.
All right. Oh, yeah. See, I forgot. I forgot to talk about my summit. So I host a summit every year with Dr. Talks, a menopause summit. And it just happens to be good timing. You can start signing up for it next week. It's going to be live October 1st through 7th. I've done 50 interviews. And it's a really good source of information. If you enjoy listening to me every day on the 7 days, it starts off with me doing a 15-minute talk. There's also an interview with me and my son talking about testosterone. And there's just interviews with a lot of the big leaders in the field, from Dr. Perlmutter to Dr. Jess to, I've got a lot of really good interviews on there. So you can go to my Instagram, Dr. Sharon Stills, and follow me. As of next Tuesday, I'll put the link in my link tree where you can sign up for the free summit. So I highly recommend that. This is my third summit. So, you could access through Dr. Talks the other two. I try to do totally different interviews every year. So it's all new. As far as connecting with, so I practice in Arizona. We are taking new patients. You can, my website is drstills.com. What were the other questions? Resources. I think I gave resources. I said some books. My summit is a lot, and then I tend to teach a lot. Maybe me and Vibrant will do something else, and we can continue teaching deeper and more, because I'd love to take a test and really go through every page with you. But we are taking new patients. You asked that. As far as other practitioners, my son, because I trained him, he's in Arizona too. He'll be practicing with me at my new clinic. Unfortunately, I don't have a lot of doctors out there that I refer to. It is a big problem. I'm trying to figure out, how to get better referrals, because I teach and I give back as much as I can, but I don't have an actual professional training. I'd like to. It just, we're opening a new clinic, and, it ends up getting pushed to the bottom, unfortunately. But hopefully, you can use some of what you learned today and question, right? We tend to give when I teach or at my summit, we give checklists, these are things you want to have a physician doing your hormones who do they do these things? How do you test? Are you supporting the liver? How are you dosing? So that you can start to weed out, oh, this person seems to, know what they're talking about, or this person doesn't. If they're not doing 24-hour urine testing, to me, it's a big no. They're missing the boat. So I don't know, make sure they're doing Vibrant testing is what I would say. That's a good way to rule in or rule out.
Well, wonderful. Well, that is all the time that we have for today. I'm going to add, remember, you have access to the, actually, I'm going to see. Oh, there we go. If I muted Dr. Stills, then I don't have the echo. So you do get this promo code. You can utilize it to do some testing, give it out, give it a try. Remember, we have that new test format with the pathway on there, so you can really start to dive in and start learning how to apply these metabolites onto a steroid, of the patient's results onto a steroid pathway. So you really can kind of walk it all the way through. Refer back to the slides from week 1, where we do kind of chunk through an entire test, so you can really see the highlights of all the analytes. And then, as Dr. Stills recommended, also see the interpretive guide for the urinary hormones. It's 80 pages long. It is so complete, and you can do that. Please remember that we also have one more week of our hormone boot camp. Next week, we have Dr. Brandon Brock, who's going to be talking about the menopausal brain, which is so important. So things like mood disorders, how it connects to neurotransmitters, estrogen in the brain, all of those types of things. This is going to be a great presentation as well. So please join us for that. So use your promo code. All the recording and slides will be sent to you. Thank you for all your engagement today. We really appreciate it. And everyone, have a wonderful day.